The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. That was Phil Collins again. We closed off with him on the last webinar, and we're continuing with him for probably a couple of songs today. And I'm Dr. Minarsik, and today is December 23rd, and it's Thursday, and it's the Thursday before the Christmas, and it's also not only webinar 24, but it's the last webinar before Christmas, because the next one we do will be next week. And Christmas is Saturday, and thank you for the Merry Christmas and good morning wishes. This will be our third out of 4 webinars on the respiratory tract. The first one we did upper respiratory. The second one we did general lung diseases. Now today, Thursday, we're going to do only pneumonias, which is, probably the single biggest topic with respiratory pathology. And then next week, after Christmas, we will do nothing but lung tumors just for a little bit. And then we're going to have a full histopathology lab to catch up with all the diseases, especially the respiratory diseases, that we've had since our last virtual microscopy lab. I don't think I have anything else to say. So we'll close off this guy over here, and we'll open up our PowerPoints. And I guess this is a good place to start. Pneumonia. Or maybe I should say pneumonias. I don't know if you recognize this as a lung. You might recognize this as a large pulmonary vessel with blood and some bronchiole or bronchus because of the epithelium. But all this is filled with inflammatory cells and fluid. So this is probably a good general image of what you can have in your mind, knowing we'll be talking about primary pneumonias today. I guess this will be our topic for today. And I guess if you wanted to classify pulmonary infections or pneumonias or pneumonitis, whatever you want to call it, you could probably classify them into the common community hospital, or I'm sorry, community acquired bacterial pneumonias. Then you could talk about the community-acquired non-bacterial or atypical pneumonias, which are primarily non-bacterial, viral, and so forth. Then the so-called nosocomial pneumonias, the ones that are acquired in the hospital. And then what kind of pneumonias you might get from aspiration, and what some of the consequences are of pneumonias, especially aspiration, are the lung abscesses. Then we have a little thing here called chronic pneumonias, and that might be confusing to you because technically a chronic inflammation of anything has a characteristic type picture. But with classification of pulmonary infections, the chronic pneumonias generally mean long-standing, okay, not necessarily resolution of an acute pneumonia. And these, if you notice one thing about all 3 of these is that they're not only are they fungal chronic infections, but they're granulomatous as well, okay? Then we'll talk about pneumonias in the immunocompromised hosts and specifically HIV patients. So, what are some of the basic considerations we might think about with pneumonias? If you want to call it a pneumonitis, you can. They're basically overlapping terms, although pneumonitis sometimes has a little connotation of viral or interstitial pneumonia rather than the bacterial pneumonias. And we're going to differentiate them from injuries, which we talked about before, acute pulmonary injury, the so-called family of obstructive or chronic obstructive lung diseases, which we talked about last time, the so-called, excuse me, a pathophysiologic classification of restrictive diseases, which we said were loss of compliance or inability to transfer air properly. Perhaps infiltrative might have been another word we use. And the vascular diseases like the PE, pulmonary embolism. Now, of course, even though neoplasms could be associated with pneumonias in different ways. We're going to save that and the inflammation associated with neoplasms or the pneumonias into the next webinar. If you remember, way back when, on one of the first webinars, this is the 24th, we talked about the classical appearances and causes and stages and cascade of things that happen during inflammation, acute inflammation, organizing inflammation, chronic inflammation. Well, there's probably no better place in the whole body that applies to except for the lungs. Now, another type of pneumonia classification or consideration are the lobar pneumonias, which involve primarily a lobe and is generally often limited to a lobe, even a single lobe, versus the bronchopneumonias, which by definition are generally caused by a preceding bronchitis, bronchiolitis. Okay. We'll talk about the interstitial versus the alveolar pneumonias. Okay, in an interstitial pneumonia, the primary place of inflammatory cell infiltrate, primarily lymphocytes, is in the alveolar septum or interstitium. And the classical bacterial pneumonias, you often see the actual alveoli filled with polys, neutrophils. So here's a normal lung. Here's an interstitial pneumonia looking like the interstitium or the tissue between the alveoli is thickened. And here's a alveolar pneumonia in which the alveoli are filled with neutrophils. Okay, that's probably a better image over there. Normal, alveolar on the right, interstitial on the left. There's a difference. Let's see. Also, where you acquire the bug, these are basically mostly or primarily infectious pneumonias, is also important. You know, most of them are acquired outside the hospital. We'll call that the community. But once you enter into a hospital, you expose yourself not only to a whole host of bugs, but a whole host of bugs which are very super in power because they have survived the massive amounts of different antibiotics that are being administered in the hospital. So those could be even worse. Now, like every infection, like every infectious organism can be powerful, weak, super powerful. But the big factor in defending against that is your host immunity. Most people overemphasize the agents and unemphasize the immunity. But the more we think and talk and study about pneumonias, we know the primary consideration is the host immunity rather than the etiologic agent, because most of these agents we'll be talking about are with us constantly, okay? Pneumonia. I had pneumonia a year ago. It almost killed me, okay? What are the two primary presenting symptoms? Why to go to the hospital? Cough and fever. Cough and fever are the two big symptoms. What are the two diagnostic methods? Well, how about a chest x-ray? And how about, hopefully, but often not possible, positive blood cultures for the characteristic organism. Now, what are these organisms? If you really look very hard, just about any organism you could ever think of, bacteria, virus, fungus, all the classical human pathogens have at one time or another been indicted as the etiologic agents or the causes of pneumonias. But what else causes pneumonias? What are some of the things involved in the reduction or the loss of the immune reaction? Well, if you can't cough, then you're not going to be coughing out the potential bugs that could cause pneumonia. That's the most obvious one. If you remember, the lining of the tracheobronchial tree is pseudostratified ciliated columnar epithelium, and there are a bunch of diseases actually in which you have a malfunction of the cilia, and also diseases which we have not talked about specifically, in which there is a underproduction of mucin. These are two big protectors. You have these two guys not working well, and this is a big predisposing factor of just about any pneumonia, especially the bronchopneumonias, which start out as bronchitis, don't they? Macrophages roam throughout the lung, roam throughout the alveolar walls, protecting, phagocytizing. What if you have some altered function of your macrophages? That's another big loss of immunity and a predisposing factor for pneumonias. It should also go without saying that if you have flow impairments of blood, this is probably true with just about any type of disease. Any disease that does not get enough blood flow cannot properly organize or enact or enable its immune system. So that's another big factor. Now, what about airflow or bronchial flow impairments? What if there's air trapping? What if that flow of air can't move in and out? Some of which moves out the bad guys, okay? Well, these are all theoretical pathophysiologic factors that would increase your chances of getting pneumonia. Now, I'm going to show you a picture now. I'll call it a picture, but it's really a sentence. I'm going to show this thing 3 times. And I hope you don't learn this the hard way like I did and other people have. You know, you're going to have somebody come into the hospital. You're going to diagnose pneumonia on a chest X-ray, maybe blood cultures. You're going to treat them. They're going to get better. The usual outcome is to completely spontaneously heal and full resolution of the pneumonia. And then that person's going to come back. Why? Because once again, pneumonias just don't happen by themselves. They happened because of decreased immunity. So even though you've cured that person on the X-ray and feeling better from pneumonia, you have not necessarily taken away these predisposing factors. So many pneumonia patients come back to the hospital, okay? And the more you understand what the immune problem is, the more you are likely to keep that person from coming back. Okay, and once again, here's our classification. We talked about it before. Community acquired, you get it outside the hospital. Bacterial, these are your common pneumonias. This is probably 90% of all pneumonias. The rest of these are 10%. Oh, maybe, well, no, with viral pneumonias, maybe more than 10%. Community hospital, atypical are viral and mycoplasmal pneumonias. Here's the things you get in the hospital. MRSA is at the top of the list, but there's a bunch of other ones. Aspiration pneumonia, due to the fact that perhaps you have aspirated. The chronic pneumonias, and I really should put that thing in quotes again. I feel guilty every time I just put that word chronic in there, because by chronic, I don't mean chronic inflammation in the classical sense of the word. I mean chronic clinically, pneumonias that go on perhaps for years and years and years. And in this category are the fungal or deep fungi, systemic fungi infections, especially the big 3, histoplasmosis, blastomycosis, coccidiomycosis. And of course, at the very top of the list is tuberculosis. Okay, that's considered a chronic pneumonia also. And what do these 4 things all have in common? They're also granulomatous. So would it be a fair thing to say that the granulomatous pneumonias generally are chronic in clinical nature? Absolutely, that's a true statement. What happens when pneumonias are out of control and they actually not only destroy the tissue that they're in, but they can dissect outside the lungs into the spine, okay, into the chest wall, into the pleura. Well, now we have abscess formation, okay? And of course, I would like to clarify this last statement here. There is a couple of pneumonias that are very, very common in immunocompromised patients, immunocompromised hosts. And of course, we will put HIV at the top of the list. However, just about every pneumonia probably has some factor of impaired immunity. Keep that in mind. We're going to see this thing at least 2 or 3 more times because it's so important. Okay, so let's talk about the community-acquired pneumonias now at the top of the list. Without a doubt, the single most common type of bacterial pneumonia is something that a bug, strep that used to be called Diplococcus because it occurs in pairs. It's gram-positive like all strep is. And the specific name is Streptococcus pneumoniae. I guess you could describe the bug as a gram-positive Diplococcus, okay? There is a gram-negative Coccobacillus. In other words, it's a gram-negative rod, but it's short, so they call it a Coccobacillus. And that's H. flu. This is the primary bug that affects not only the lower, but the upper respiratory tract in children, especially under 2. Moraxella is another gram-negative Coccobacillus. And isn't it interesting that these 2 bugs here, number 2 and number 3, both of the gram-negative short Coccobacilli, are also the primary infectors, secondary infectors of people with emphysema as well. Staph, okay, can be a pneumonia just like strep can. In particular, though, staph loves to be a secondarily infector after viral pneumonias, okay? Klebsiella, also on the list, you can't exclude that, particularly in debilitated people, alcoholics, people you find laying on the street all night, unconscious or with pneumonia. Pseudomonas, a big one, and something that was relatively unheard of a couple generations ago, but it's now on the top 7 list, Legionella, another bacteria. These are all bacteria that are spread by fine water droplets. So here's the big one. Here's the kind you're most likely to get. It's also the most common type of lobar pneumonia. So strep pneumonias are generally lobar, which means they involve the entire lobe of the lung, a right middle lobe, the left upper lobe, okay? The reason why I say lobar is very often it involves primarily and perhaps entirely just one lobe. And then when you come to the fissure of that lobe and you go onto another lobe, there's no pneumonia at all. So strep is the primary most common pneumonia. It's also the most common pneumonia in immunocompromised people, and it's also the most common lobar pneumonia. This bug, Streptococcus pneumonia, is about in 1/5 of everybody, and sometimes, due to lack of immunity and other things, it goes wild and causes a lobar pneumonia. Now, if you would like to verify that a person with a lobar pneumonia has strep, of course, you want to do the other. With a chest x-ray infiltrate, you might want to do the other thing and verify it by a blood culture. Well, bad news. Only 20% of the time will they have positive blood cultures. But good news is they are generally treated quickly and successfully and thoroughly. And I would like to say irreversibly, but they often come back to with penicillin-type antibiotics, and it's 100% curative. And of course, you know, there's a vaccine, probably even more important than the so-called flu vaccine, and they are effective as well. Here's a lobar pneumonia. I think I showed you this picture tiny, but now I'm going to blow it up. Look at this is one lobe of the lung. You can see a major fissure here, and you can see another lobe of the lung. Why is this one yellow and looks more like liver, and this one is sort of red and spongy like a lung should look like? Because this is a lobar pneumonia, primarily limited to a single lobe. Okay, there are other lobar pneumonias, but this is the most common one. I think Legionella is probably lobar usually too. Look, chest x-ray, same general appearance. Check this out. Do you see how this infiltrate is dense, but it's primarily limited to the right upper lobe? Okay, that's a lobar pneumonia. Look at it. Here's your fissure again, and look. Right underneath it, in the right middle or lobe, I think it's the middle, I guess it could be lower, but right underneath it is a normal lung lucency. Probably the single best image of an acute bacterial pneumonia is something like this. Hold on, we're going to put that back. Okay, normal lucency, normal lucency, normal lucency, totally dense right upper lobe. Check this out. These are alveoli, and these are neutrophils within the alveoli in the acute phase, of course. Take a look at the septum or the walls of the alveoli. They are generally nice and thin like they should be. Oh yeah, they're probably hyperemic. They probably have dilated capillaries. But this is the classical appearance of just about any acute bacterial pneumonia. Polys in the alveoli. Okay. Now, if you were to take some of these polys by way of a sputum or by way of smearing the biopsy or the autopsy, you would see these are gram positive because they're dark. And look how they're in pairs. Two there, two there, two there, two there, two there. That's why it's called Diplococcus. And it's round, so it's a coccus. And you can see some of them are even inside the neutrophils, okay, which is where they should be. And do we have anything else to show on this? Was there anything else? No. This is the classical picture of acute bacterial lobar pneumonia. H-flu. H-flu is without a doubt the biggest, most serious, most common upper and lower respiratory tract offender in small children, specifically under 2. If you have a baby under 2, has an ear infection, has an upper respiratory infection, has a meningitis, it's the number one without a doubt. Any kid under 2 with meningitis is presumed to be H-flu. Even osteomyelitis and cellulitis. Now, it's not gram positive, but it's gram negative. And it's not a coccus, it's a bacillus, but it's a short bacillus. That's why they call it a gram-negative coccobacillus. So it's not going to be blue, it's going to be red, and it's going to be short. Okay? And here we go. I'll say it again. Actually, it's in writing now, okay? So it's not just me saying this. Pneumonias in kids under 2 are often thought of as being H-flu until proven otherwise. Same thing with middle ear infections and almost all of the meningitises too. Most meningitises are bacterial, and almost all meningitises in kids under 2 are H-flu bacterial. And it's also, in adults, the most common secondarily infector of COPD. Okay, so when you have your chronic obstructive, your emphysema patients getting pneumonias all the time, H-flu is the number one culprit. And I think Moraxella is very, very high on the list too. This is treated with Bactrim, I am told. I am no big expert on treating them, but trimethoprim sulfa is a very good treatment for it. And look at, what do we have here? What we have here, whoops, sorry. Let's see if we could do that again. These are gram negative now. You see how they're red? And they're not in pairs, they're single. But they are short rods. And some are in cells and some are free. This is a gram stain. So this is H-flu looking like it should look like. Here is a meningitis. And here is, you could see the gyri of the brain. you can see the meninges are just loaded with acute inflammatory cells. And if this was a kid under 2, I mean, you could culture it or do a gram stain or whatever you want to do, but you know what most likely it's going to be anyway, H. flu. And this is what meningitis might look like grossly, an autopsy, what they call cloudy meninges. If you ever have a report from a neuropathologist on a brain examination, he will always say the meninges are not cloudy, or they'll say translucent, or you could read a newspaper through them, but here they're dull and yellowish, and this is all pus. Okay? And here's a kid, or I don't know, maybe it's not a kid, but you can see an infiltrate there in the right lower lobe. So that's a pneumonia until proven otherwise. But actually, it's really all it is basically is an infiltrate. Could that be a tumor underneath there? Could it be a tumor causing the inflammation? Could it be a viral pneumonia? Could it be another bacteria? Of course, but this happens to be an acute bacterial pneumonia, H. flu. Or it could be a person with chronic lung disease with a secondary pneumonia. How about that, if it's H. flu? Moraxella. I'm going to mention this. Maybe it's a bacteria you may not have heard of too much, but after H. flu, it's also, like H. flu, a gram-negative coxobacillus, just like Haemophilus influenza, but it's the second most common complication of emphysema patients after Haemophilus. What about staph? You know, looks like we've kind of ignored, you know, the most common bacteria in the world. Of course, they can cause pneumonias, but they are probably just as likely, or perhaps even more likely, to be secondarily infectors following viral pneumonias. And as of yesterday, I put something in there that should have been there already for years, just like skin. People with herpes lesions very rarely just have pure vesicles. They're usually ruptured vesicles and secondarily infected with staph. So just like staph often secondarily infects viral skin lesions, it is also the most common pneumonia following viral pneumonias as well. Okay, now there's a special type of staph that's called MRSA, MRSA. It's a very, very, very serious concern in hospitals, and a cause of a lot of lawsuits as well. Because in the hospital, staph, in other words, methicillin-resistant Staph aureus, is not community acquired, but it's hospital acquired, which makes it nosocomial. So, but even the non-MRSA can be a common viral pneumonia as well. Klebsiella. Klebsiella pneumoniae, another gram-negative rod. It's often found in people that are debilitated, malnourished, alcoholics. In fact, here, I'll make a statement here. Let's say, even though there's a lot of alcoholics, okay, if you find an alcoholic sleeping under a viaduct at night and he's sick with pneumonia, chances are that's Klebsiella. In fact, I don't think this is my quote. I think this is something I got from a textbook. The alcoholics with pneumonia are often thought of having Klebsiella as the bacterial cause until proven otherwise. So what's the one word you can associate with this community-acquired pneumonia? The debilitated, malnourished alcoholics. How about that? Pseudomonas, okay? It's usually not community-acquired, okay, but why am I putting it in here as community-acquired? It's because patients with cystic fibrosis when they have complications and pneumonias into their lungs because their lungs have plugged up ducts, and so does just about every other glandular organ in their body, theoretically. If you have a cystic fibrosis patient with pneumonia, it's most likely Pseudomonas. And by the way, Pseudomonas has a characteristic smell. I don't know if you've ever been to a microbiology lab, but if they have a Pseudomonas culture there, not only will you smell it, but you'll probably remember the smell forever. Legionella is the last bacterial community-acquired pneumonia. It was described, during my lifetime, maybe 30, 40 years ago, I don't know, as an outbreak in a Legionnaires' convention, okay, in which many people were exposed to droplets coming from the ventilation system, okay, and a lot of them came down with pneumonia, and a lot of them died as well. So Legionella is called pneumophilia, okay, spread by water droplets primarily. And once again, of course, it's more common in classically immunosuppressed patients than non-immunosuppressed patients. However, here's my sign again. Even though it's more common in classically immunocompromised patient, any pneumonia probably has some type of underlying immunosuppressive factor. Okay, so there are some bugs that they could just throw at you and they'll cause inflammation, infection. But when somebody gets a pneumonia, it's probably something underlying that allows that pneumonia. Okay, you might remember me saying a little bit ago that when we talked about classical phases or appearances or the sequence or the cascade of acute inflammation, and then we talked about organizing inflammation following acute inflammation, and sometimes that could go into chronic inflammation. Here you have neutrophils. Here you have endothelial cells, macrophages, and maybe the early appearance of fibroblasts. In chronic inflammation, you have mononucleated cells, lymphocytes, macrophages. Okay? We talked about their appearances. Well, guess what? Probably the best place to give an example of those are in pneumonias, the bacterial pneumonias, okay? Now, can you have fibrosis following chronic inflammation, acute inflammation? Of course. Could you have full resolution? Of course. That's one of the that's one of the common outcomes as well. It's the hopeful outcome. That's when the infiltrate on the chest x-ray disappears, isn't it? So, what can we say? What we can say is that the usual successful outcome of these community-acquired bacterial pneumonias is full resolution. How do we know that? Because the infiltrate goes away. And if, for example, you had a chance to examine that lung, afterwards, it's going to look pretty close to normal histologically. That's the hoped for and also the most common outcome. Now, during this evolution from normal lung to neutrophils to new blood vessels coming in, perhaps to some fibrosis and back to full resolution, the lung, of course, that infiltrate is going to cause the lung to look more like liver than lung, okay? Because why? Liver is solid, lung is spongy. So sometimes the word hepatization is used in the morphology, especially the autopsy morphology of pneumonia. And the early stage is red hepatization. Why? Because the primary focus is on hyperemia and hemorrhage in the early stages. And then in gray, You can say could that be maybe organizing or fibrosis? Yeah. So there's the so-called red hepatization followed by gray hepatization. And another word that's used, probably even more appropriate than hepatization, is the word consolidation. So what is consolidation is? Well, consolidation is you have something spongy, like a sponge, and all of a sudden it feels like a rubber ball, okay? It consolidates. That's what causes the infiltrate. That's what causes the loss of lucency. That's what causes the infiltrate. Now, sometimes the word infiltrate is also used in the histopathology. Why? Because what actually causes that spongy thing to become rubbery and firm? It's the infiltration of inflammatory cells, okay? So you'll often see the word infiltrate seen not only in x-ray but also in histopathology as well. Now, if you have a sponge and you squeeze it, it feels bubbly, okay, that's crepitance. But if that sponge is now firm, you don't get that bubbly crinkles anymore, do you? So loss of crepitance is also another word that is used to describe the changes, particularly gross changes of the lung in pneumonias. Okay, I think we're going to go, that was the single biggest category that we just talked about, the community acquired bacterial. I want to get this thing off my back as well now because, you know, when we talk about the atypical pneumonias, we're talking about the viral pneumonias. And I have promised myself, I have sworn to myself that I am not going to talk about that horrible and often confusing and often misleading disease called COVID. So I'm not going to spend that much time talking about the atypical or viral community-acquired pneumonias. I guess you could say the viral pneumonias in general are community-acquired. Not only that, but they could be epidemics, they could be pandemics, and of course I'm going to use influenza as the big example. I'm going to try very, very hard not to use the C word today, but if I do, it'll probably be used in anger, okay? Another type of non-bacterial community-acquired pneumonia are the mycoplasmas. They are not bacteria. Sometimes they are called obligate intercellular bacteria, but they don't totally fit the definition of a bacteria, like it doesn't have a bacterial wall, for example. And therefore, cultures are not helpful. And all the other ones that we talked about, the community-acquired pneumonias, we could culture these specific organisms. But I think a good definition of atypical would be either viral or non-bacterial, in which cultures are not helpful. Now, here's something we're going to have to say, because viral is at the top of the list. And you know there's a viral pneumonia today. It almost killed me about a year ago, but it's, you know, so-called pandemic, okay? The thing you should know about the viral pneumonias as compared to the bacterial pneumonias in general, okay, is that in the bacterial pneumonias, remember we showed you this picture before? We talked about basically neutrophils, you know, gobbling up the bacteria inside of the alveoli, with the alveolar walls being relatively preserved and thin, although maybe hyperemic. And the viral pneumonias are often called interstitial pneumonias because they don't so much involve the alveoli being filled with inflammatory cells or neutrophils, but they involve mononuclear cells, lymphocytes, fibroblasts, macrophages, thickening the actual wall of the alveolus, something you might call the alveolar wall or alveolar septae. So, if you remember when we talked about inflammation, we said that the general inflammatory cell for viral infections were lymphocytes and macrophages. In other words, cells that we called mononuclear cells. And we said that the general inflammatory cells, acute inflammatory cells for bacteria were neutrophils. So in viral pneumonias, you're basically getting more thickening and changes in these alveolar septae than you are in the alveoli themselves. In general, okay, it's a principle that has some exceptions to it. But I would say if you showed both of these pictures to a pathologist and said, which one is a viral pneumonia and which one is a bacterial pneumonia, it would be a slam dunk reflex. He would say, oh, it's a virus on the left. We'll talk about the flu virus, single biggest killer of all time, no matter what kind of BS you hear on CNN. Influenza virus had true pandemics. 1915, 1918, a good portion of the world died because of that. Type A was the big one, okay? Now, over the years, it has mutated and has caused, evolved into many different strains. You know, maybe they ran out of the Greek alphabet for that one. The avian flu, the swine flu, blah, blah, blah. But basically the vaccinations that were given were basically ultimately effective against the original 1915 and 19 type A viruses. There's a type B and a type C primarily in children, but all of these different strains, you know, just like with the COVID so-called virus, they can totally be identified by PCR. Well, you know, maybe I shouldn't have said that because in all honesty, I don't think anybody has ever really totally shown us clearly, you know, the structure and exact sequencing of the so-called COVID virus. And that's all I'm going to say about it. But I will say that one of the viruses also is a coronavirus. Here's a chest x-ray again. If you are not a radiologist, you might think it's kind of normal, okay, sharp costophrenic angles. But down here in the right lower lung field, you can see that it's a little bit less lucent than it is in the other lung and in the other part of the lung. So this you could call a subtle right lower lobe infiltrate, okay? And I think you don't need a radiologist to tell you that, but probably a radiologist would just look at it in 2 seconds and say, oh my God, it sticks out like a sore thumb. SARS, coronavirus, okay? There was an outbreak about 20 years ago in China, and then we have all of this massive insanity in the last couple of years too, which I refuse to talk about. And basically, it was a outbreak. There were some deaths, but it was not a worldwide pandemic, okay? It might have been feared at the time, okay? And please don't ask me my opinion about COVID because I'm going to say something that might get me put in jail, okay? It's like any other viral pneumonia. It could be confirmed by PCR. You know, it's called corona because it's a virus that's surrounded by these spiky little things that make it look like a crown, the so-called spike proteins, okay? And classically, it's a virus. So it's going to look like a viral pneumonia. We're going to see more of an interstitium or septum infiltrated, maybe some giant cells, but not like the pneumonias that you see with acute bacterial pneumonias. Well, this is the crown. These little spiky things, spike proteins are the crown. That's why it's called corona. And you might not know this, but coronaviruses are very common causes of upper respiratory infections, okay? In this case, it was the cause of SARS, okay? And that's why it's called corona. It's an RNA virus too. Do we want to say anything else? No. I'll tell you what, this is a good time to take a little break. Okay, we have probably covered about half of what we're going to cover. So when we come back after our music break, We'll talk about the nosocomial, or in other words, hospital-acquired pneumonias. Some of them are the same bugs that we see here in the community-acquired, but most of them are generally kind of different in terms of their frequency. Okay, so how about if we drop this down and we look at our nice little Christmas lights again, which is going to be over here. And we'll see you in about 10 minutes. And make sure you can see those nice little flashing lights. Oh, there we go. And we'll hear some more stuff from Phil Collins and probably some other people as well. Okay, see you in a little bit.
Please give me one more night. Give me one.
Okay, we're back and we'll talk some more about pneumonias. I was reading your comments during the break and somebody said that my professional opinion is important. I've been teaching pathology and immunology for 12 years and I'm a board certified pathologist. Certified by ABP, the American Board of Pathology. But let me tell you what these motherfuckers did recently. There's a doctor, I'm not going to give you his name, he gave a speech at the most prestigious association of physicians and surgeons in the country. And basically he says masks don't work. And COVID is more about control of a population than a real medical disease. Even though I almost died of a viral infection almost a year ago, I totally believe him, and that's my opinion about COVID. So the reason I'm not talking about it is there's been so much lies and government propaganda about this to create fear, to control people. It's no longer in the realm of medicine or science, okay? And I've made my statement, and that's my opinion. And I guess if I worked for a university teaching like I did last year, I'd probably be fired. Certainly if I worked for the government, I'd probably be assassinated for saying this. So let's continue on, now that I feel a lot better now, with our discussion of pneumonias. It's going to get even more interesting, folks. Nosocomial. It doesn't mean that it starts in the nose. It means you acquire it in the hospital, and that's our third category out of 7. The people that are in hospitals, not only are they exposed to all of the bacteria that are flying around, but it's bacteria that have been treated with antibiotics. So a lot of them are resistant to the common antibiotics that would normally kill them. Hence, MRSA, the number one fear of the hospital, methicillin resistant Staph aureus. Usually methicillin zaps those bugs, but the ones in hospitals very often are resistant to it, okay? That's basically, I've heard a very important wise person say, as soon as you step into a hospital and take a breath, you probably inhaled some MRSA, okay? But people in hospitals are being treated with antibiotics, so it's not unusual that many of them bugs become resistant. People are debilitated. They have catheters sticking into them. They're on ventilators. And Enterobacter, Pseudomonas are high on the list. We talked about Pseudomonas before. We talked about staph before, but the nosocomial staph is generally regarded as methicillin resistant. But here is a list of other bugs, some of which we talked about, some of which we haven't talked about. Okay, we talked about 4 out of these 5, but E. coli is also on the list. So these may not be, for example, strep pneumoniae, okay, that's high on the list, and a little bit lower on the list for nosocomial infections. What happens if you aspirate gastric contents into your lungs? That's pretty horrible, isn't it? Because you have gastric acid and maybe food, okay, and all kinds of bacteria-laden material. And that's the cause of aspiration pneumonia. People either accidentally or have problem and they aspirate food because maybe they can't swallow properly, okay? Aspiration pneumonias occur, of course, in unconscious patients. They have no idea that it's happening. Patients that are in prolonged bed rest. Patients that have loss of ability to swallow or gag. You lose your gag reflex and you're in deep, deep trouble. Okay, they can't cough it out. Okay, and that happens often. Probably every day you may aspirate a little bit of your food, but you may cough whether you realize it or not. And if you can't cough because you lost the ability to swallow or cough it out, gag, you may be a victim of aspiration pneumonia. Gastric contents are terribly corrosive, have the pH very similar to battery acid, okay? And of course, because most of the patients are in prolonged bed rest or unconscious, they're probably laying down, so the food is going to go into the gravity-dependent portions of the lungs, which of course would be posterior. Okay, if they were standing up, it would be inferior at the lung bases, but that's the most likely places for aspiration pneumonias. And even though the lower lobes would be the place for the gravitational most common place for aspiration if you're standing up, they are also, gravitationally speaking, the superior segments of the lower lobes are the most common place for gravitational passage of food if you're lying down. And if you don't believe me, just lay down or have somebody lay down and take a look at what the most gravitationally dependent portion of their chest is. And of course, because you're aspirating a tremendous amount of destructive material, this can lead to abscesses, and abscesses can cause destruction not only in the lungs, but anatomically speaking, dissect into all of the lungs' neighbors too, not just pleura, perhaps even into the spine, okay, perhaps even into the chest wall. The type of x-ray you might get in an aspiration pneumonia would be a patient that cannot walk to radiology and stand up. They're probably in their beds in ICU. And you could see massive infiltrates here in the right middle lung field and all throughout the left, and actually kind of sparing the lung bases, okay? But if that patient was standing up when he aspirated and kept standing up, probably the infiltrates would be more inferiorly located as well. That's what we mean by gravity. Could these lead to abscesses? Of course they could. But a good general rule is that any pneumonia which is severe and destructive enough, if it's untreated, or even if it's treated sometimes, can lead to a lung abscess. Furthermore, they can embolize. These septic emboli can get into the bloodstream and embolize all over the body. Okay, very often you see this with the neoplasia, okay, where you have, just like in a neoplasm, causing a destructive process. Well, the lung abscess can do the same thing. Now, what are the lungs' neighbors? You know, the esophagus has to be one, right? The spine, the pleura, and the diaphragm. And when you have a collection of pus from a lung abscess, because an abscess is defined as nothing but a big bag of pus, when that dissects out into the pleura, the pleural space, technically between the visceral and parietal mesothelial lined surfaces, then you get a situation known as an empyema. So what is an empyema? It's pus in the pleural cavity. This should be as boring as hell. You can see that there is a normal kind of sponginess and some residual alveoli here in the northeast, and in the southeast and in the southwest. But the very majority of this field, especially the upper lung field, is nothing but basically neutrophils and destroyed, completely obliterated lung tissue. I mean, here you could recognize relatively normal lung tissue. Here you could see maybe lung tissue totally infiltrated by neutrophils, but up here there's not any lung tissue. In addition, there are these big globs of stuff, like here. I know you're probably thinking already, well, what is this? What is this? What is this? That could very easily be food, okay? So it's not very often, it's not very uncommon, where you can actually see food particles, vegetable fibers in aspirated abscess materials as well. Chronic pneumonias. Once again, I'm going to say it, is that chronic pneumonias is just not chronic inflammation in a pneumonia. It's a category of clinical chronicity rather than pathologic chronicity, okay? It's a pneumonia that lasts often a lifetime, very often, as a rule, many years. And it's, if you remember that we said that granulomatous inflammation was a type of chronic inflammation, you can also see it that way as well, because the classification of clinically chronic pneumonias, besides just having the chronic inflammation phase of acute pneumonia, are basically granulomatous diseases. And TB is the number one granulomatous disease, but we also have these deep fungal diseases, or the systemic fungi, not just the dermatophytes, not just the superficial skin fungi, but the deep systemic fungi, histoplasmosis, blastomycosis, and coccidiomycosis. So let's talk about them. If somebody was to ask you to give a differential diagnosis of the classical granulomatous diseases, these would be most of them on the list: tuberculosis, histoplasmosis, an organism called Histoplasma capsulatum, blastomycosis, which is short for Blastomyces dermatitis, and coccidiomycosis, also a deep systemic granulomatous fungi. The main bug being Coccidioides immitis, okay? We say chronic, we're talking about chronic time-wise, not necessarily chronic by the classical chronic inflammation pattern, because they are granulomatous chronic inflammation. The other type of granulomatous inflammation is sarcoid. We covered that already. That's basically an autoimmune disease. Another type of granuloma might be reaction to a foreign body. So whenever you think of granulomatous inflammation, always think of four things: TB, fungi, foreign bodies, and sarcoid. Here's the bug of tuberculosis. I'm not going to go into a full-blown description of it, but it's acid-fast. It doesn't stain with the gram stain. It's not gram-positive or gram-negative. It's basically what they call an acid-fast stain, staining red. The stain is also called the Ziehl-Neelsen stain. Here it is inside of macrophages, because TB is a granulomatous disease, and granulomas are basically clusters of macrophages. Sometimes you see them inside the viable cells. Sometimes you see them in necrotic areas. And the necrosis of granulomatous TB is classically called caseous necrosis, because it looks and cuts like cheese. Okay. Histoplasmosis is the smallest of the fungal organism. In a granuloma of histoplasmosis, you can see these are basically macrophages here, and these little blue dots inside of the macrophages, there's a bunch of them here, there's a few here, there's more here, are basically small enough to have many inside of one cell. They're very tiny. Okay, that's histoplasmosis. In blastomycosis, you have what they call spherules. So here we have a cluster of what look like macrophages. But you see there is a big ball, much bigger than a cell. There's one, there's one. And if you stain them with the classic fungal stains, There's several of them, but the silver stain is the most common and probably the most specific one. You see that they are big black balls, blastomycosis. The reason why it's called blastomyces dermatitidis is the main organ is because it's also very common as causing skin and soft tissue granulomas as well. And it's worldwide. It's in North America, South America. They have a variant called North American blastomycosis versus South American, but basically it's a fungal, deep systemic chronic disease. Here's coccidio. And look, we also have these little spherules in coccidio, but they're not that much bigger than cells. Okay, so they generally say these spherules of coccidiomycosis are generally smaller than the spherules of blastomycosis. So blasto are bigger. How do you like that? Here's histo now. Histo, they always describe histo as being, in the United States at least, in the endemic in the areas of the so-called Mississippi Valley, Ohio Valley. Okay, but look at, if you took the area of drainage of the Mississippi and Ohio River, that covers not only the majority of the United States, but even goes into Canada a little bit. The only place it doesn't seem to apply very much is in the Southwest. And there's another fungus that's even makes up for that, because the next one of the other funguses we talk about, coccidio, is basically endemic in the Southwest. Clinically, it's a chronic granulomatous disease. Not only pulmonary, though, not just a chronic pneumonia. Histo can basically infect just about anything. For some reason, it has a very big affinity for the adrenal glands, just like lung metastases often love to go to the adrenal glands as well. The granulomas of histoplasmosis are usually larger and calcified, okay? These little tiny organisms live in the macrophages. And like I say, even though it's primarily mimicking tuberculosis, it can also be found in many other organs. For some reason, I keep thinking adrenal is very, very high on the list. Here is the actual bug. This picture was not taken from a textbook. It was taken from a pathologist friend who shared it with people on one of the internet forums. Those little purple dots, tiny little bugs, are inside of these foamy like macrophages, and all these little purple dots in this cluster of macrophages too. And look, here's a CT. Why are these dots so big and white and well defined on CT? Because they're larger, they're larger, and they're frequently calcified. The calcifications in the deep fungi generally are even more likely to be calcified than tuberculosis. Here's some more macrophages isolated from somewhere. And take a look. These are tiny histoplasmosis organisms causing a pneumonia, granulomatous, chronic, clinically pneumonia that you can mistake for tuberculosis. What about blasto? Well, blasto is found everywhere. They always talk about the Ohio and Mississippi Valley again, okay? It's found in South America, North America. A little bit different in terms of their behavior, so they talk about North and South American blastomycosis. It's also in soil, okay, like many fungi are. Fungi love to grow in dark, wet places. Like histo, it mimics tuberculosis. The name of the bug, the most common genus and species, is Dermatitidis. Dermatidis. Okay, because I think it's probably called dermatitis because it commonly affects the skin and soft tissues of the skin as well. And once again, they're more likely to be calcified and large. But remember, any granuloma that's present for a long period of time is likely to become calcified. And all of these granulomatous pneumonias can last for many, many years. And the spherules are basically larger than the same type of spherules you see with coccidio. The distribution is about the same as histo, and we also said that skin is probably the number 2 organ, but it is not a dermatophyte. It's a deep systemic fungi. Here's a chest x-ray. Look at those big balls there, and there, and there, and there, and there, and there. And look how big those spherules are. This is a stain, not a silver stain, but what they call a PAS stain, which is pretty good to stain fungi. Okay, and look how big they are. I would say that these spherules are probably 2 or 3 times the diameter of an average lymphocyte. Now, coccidio, similar with the rest of them, also mimics TB. The bug genus is and species is Coccidioides immitis, also often large pulmonary calcified granulomas. The spherules are a little smaller than blastomycosis. And you remember we said histoplasmosis and blastomycosis are found in the Mississippi, Ohio Valley, which was practically the whole part of the country, our country, except for the Southwest. Well, look, now we got a bug, a systemic fungus, that is primarily in the Southwest, and that's coccidiomycosis, okay? And like the other pulmonary chronic granulomatous diseases, please don't think of them as just involving lung. Just like the other 3, many, many other organs can be affected. Here's a granuloma. It's a classical granuloma. Could this be TB? Yes. Could this be sarcoid? Yes. Could it be histoplasmosis? Yes. Could it be blastomycosis in the lung? Yes. Could it be coccidiomycosis? Yes. But all you could say is that it's a granuloma. Basically, all these are clusters of histiocytes, or macrophages is probably a better word to use. Some of them has fused their cytoplasm, okay, to become multinucleated giant cells. There's usually a little rim of lymphocytes towards the periphery. Here's another granuloma over here. And with age, they become more fibrotic and more calcified. Now in this one, there is no calcification. Also, notice that in this one, there is no necrosis in the granuloma. Now that doesn't mean that it's not tuberculosis. It still could be. So this could be TB, fungi, sarcoid. Technically, could it also even be a foreign body reaction to something that was inhaled in the lungs? Yes, because those 4 things are your common differential diagnosis of granulomas. Compromised hosts. Well, we all said many times so far, I'm not going to show you that same slide, that pneumonias do not occur in fully competent people, immunocompetent people. There's always some type of lack of host defense in most of the pneumonias. But the people that are truly immunocompromised, are more likely to get these relatively rare pneumonias, like pneumocystis carinii, CMV, a virus in the herpes family that is probably the number 1 viral pneumonia in severely immunocompromised people, like AIDS patients, of course. And of course, almost every deep systemic fungus infection is not just occurring in a healthy person that lost a little bit of their defenses. Fungal deep systemic infections are generally in people that have severely compromised immunity. So, wouldn't it also be logical to say that these are the three most severe and usually rare bugs to infect AIDS patients as well? Here's Pneumocystis carinii. I put a little asterisk there because the microbiologists don't want us to call it carinii anymore. They want us to call it Girovacea, okay? So here is a chest x-ray in a immunocompromised patient severely. And if you were a radiologist, you would say, well, you know, there's kind of like infiltrates, but they're not really sharp or well defined. They look a lot like cotton wool. So very often I've heard the radiologists call these cotton wool infiltrates or woolly infiltrates. Now the reason why I like that word wool is because if you biopsied this or autopsied this and you saw a lung that was inflamed and then you did a high power view of the lung, you would see also a woolly type exudates in the alveoli. So what is cotton wool to the radiologist is a woolly exudate to the pathologist, the same word. But take a look at this particular woolly type exudate inside of this alveolus. I want to ask you a question. Do you see not only is it kind of fibrinous or woolly, but almost like there's little white things in there that are not taking up the stain? Well, guess what? Those are the actual PCP organisms. Okay, that's Pneumocystis girovacea, every one of those little white things. I'm going to show you a stain now, a good stain, a silver stain, because even though it's not a fungus, it's kind of related to a fungus in many ways. So it'll take up the fungal silver stain, and I think I have a very nice picture to show you of that as well. What else did I want to show you? No, I'll show it to you right now. This is that same thing, but it's stained with the silver stain, and the silver stain stains, besides fungi, Pneumocystis pretty well. So how would you describe these things that were formerly white with a pink woolly background in alveolus? Now they look black. These are the actual organisms, okay? Pneumocystis is a protozoan, but it stains like a fungus because it's halfway related to a fungus. The word that I've heard many pathologists use to describe these little round, black, sometimes bent or twisted things, they call them bent coins, okay? Now you could call them what you want. Maybe you think they look like something else, but this is a common word that they use to describe Pneumocystis. Rather than carinii, I will be more perfect and say Girovacea. How's that? People that get lung transplants, you have to remember one thing. This is the general category of people that get lung transplants, okay? Probably the number one lung transplant indication would be also the number one end-stage lung disease, or severe emphysema, severe chronic obstructive lung disease. I would guess age would make a big factor too. Probably a young person with severe emphysema would be more of a candidate than somebody that's in their 80s. People that have one of these younger people, especially again, with pulmonary fibrosis. We talked about the family of fibrotic restrictive lung diseases yesterday, like idiopathic pulmonary fibrosis at the top of the list. Okay, patients with cystic fibrosis. Now, these are basically kids, even though they could appear in later life. Cystic fibrosis basically is a disease we'll talk about extensively when we talk about pediatric diseases. But they basically can get end-stage lung diseases, secondarily infections. Remember we said Pseudomonas is the number one bug. to infect that, though. They need a lung transplant. And people with pulmonary hypertension. In pulmonary hypertension, not only are your lungs severely and perhaps irreparably damaged, but they could be causing heart failure as well. So these are the 4 indications for lung transplant. I think I have some pretty grisly statistics for you too. Most of the people that get lung transplants only last a few years. The statistics are half of them are basically not working in 3 to 5 years. Another disease which we talked about with the fibrotic restrictive lung diseases is COP, okay, cryptogenic pneumonia, also called bronchiolitis obliterans. That's a common finding in the rejected lungs. Of course, if it's rejected acutely, then acutely means usually within weeks or months the lungs are gone. But the ones that are not acutely rejected only last a few years anyway. And if you remember that the patients who get lung transplants are on immunosuppressives, so by definition they are made to have a suppressed immunity, then they're going to be more likely to get not just the regular bacterial pneumonias, but viral pneumonias, fungal, and PCP. And remember, these were the ones that severely immunosuppressed people get. But I want to bring up one more topic, just a statement. If you were to ask most people what is the most common pneumonia in AIDS patients, they would probably say, pneumocystis. Well, that's not true. Because remember, when your immunity is suppressed, you're still going to get the regular common pneumonia. So the correct answer is the most common type of pneumonia with AIDS patients are regular old streptococcal pneumonias, okay? I made the mistake of not knowing that a few years ago, and somebody from my medical school reminded me that I was wrong. So that's why I am passing this on to you. This is COP again. This is a lung that has been transplanted and it has failed. And you can see that there is organizing inflammation. This is all reaction against the donor. And here you have a bronchus. You can see bronchial epithelium here. And it's obstructed by this organizing fibrotic ball. And this is what you call COP, cryptogenic organizing pneumonia. And guess what, folks? I'm giving you a little bit of a break because we're done now. And in the next webinar, next week, 5 days from now, after Christmas, Tuesday, and specifically the date will be the 28th of December, we're just going to talk briefly about lung tumors, maybe in the first hour, and then spend at least another full hour looking at all of these diseases that we talked about, or as many as we can, under the microscope with our virtual microscopy lab, which I enjoy, and I hope you enjoy it too, because I don't have to prepare much for it, because these are diseases I've seen my whole life. And I also enjoy just talking about things under the microscope, because that's how pathologists do most of their teaching, is while they're looking under a microscope with somebody. So that means we're going to leave a little bit early today. And I guess we could say rock on buzzards at this time, but let's play our final song too. And maybe do a few tricks before we sign off. Rock on buzzards. I'd like to say Merry Christmas, but I would really want to say is enjoy whatever holiday you will be enjoying, and also enjoy your life as well.